Press down, twist, and the medicine bottle still refuses to open.
That resistance is deliberate. By the mid-20th century, common medicines such as aspirin were increasingly present in American homes, and accidental childhood poisonings became a serious public health problem.
Child-resistant closures were developed to make access harder for young children without making bottles impossible for adults to use.
So how did a poisoning crisis turn an ordinary container into a safety device? And why are some medicine bottles still difficult to open today?
The story begins as household medicines became easier to buy, store, and reach. Introduction: pick up a modern prescription bottle, and the first problem is obvious before you ever reach the medicine. The cap does not simply twist off. You may have to push down while turning, squeeze two marked points at once, line up arrows, or press a tab while rotating the lid. For a child, that extra motion is supposed to be a barrier.
For an adult with arthritis, weak hands, or limited dexterity,
it can feel like a small daily battle. That frustration was designed on purpose. By the middle of the 20th century, American homes were filling with aspirin,
sedatives, cold medicines, iron tablets, cleaners,
and other products that could seriously injure a young child. Poison control centers were recording thousands of accidental ingestions. Pediatricians were seeing the same pattern again and again. A curious toddler, an ordinary bottle, and a medicine that had been stored only a few feet from the floor. The response eventually changed the container itself. In 1970,
Congress passed the Poison Prevention Packaging Act, but the law did not invent the safety cap.
And it did not force every medicine into the same closure overnight. It created a performance standard. Certain dangerous household substances had to be packaged, so they were significantly difficult for children under 5 to open, while remaining usable by adults. So why did American medicine bottles become deliberately hard to open?
Why was aspirin at the center of the crisis?
And how did a child safety solution create a second problem for the very adults who needed the medicine most?
Chapter 1. When the medicine cabinet filled up in the first half of the 20th century. The American medicine cabinet was becoming crowded. Aspirin was already one of the most familiar drugs in the country.
Families kept it for headaches, fevers, toothaches, arthritis, and the ordinary pains of daily life. Children's formulations were sold in smaller doses, often flavored and easy to chew. Prescription medicines also multiplied after the Second World War as antibiotics, sedatives, cardiovascular drugs, and other treatments moved into ordinary homes. The container remained simple. A pharmacist might dispense tablets in a glass or plastic bottle with a screw cap or snap closure that an adult could open in seconds. Over-the-counter medicines could sit in large bottles on a shelf,
in a purse, on a bedside table, or inside a low bathroom cabinet. To a parent,
the bottle looked like medicine. To your old,
it could look like a rattle full of small bright objects. Doctors had been warning about childhood poisoning before the federal government considered special packaging. In 1950, the American Academy of Pediatrics created an accident prevention committee chaired by physician George Wheatley.
A survey of pediatricians found poisoning represented a striking share of the accidents they were treating. At the same time, pharmacists and doctors were building a new emergency system. In Chicago, pharmacist Louis Gallman created an enormous file of information on commercial products and their toxic ingredients. He took poison questions by telephone and helped establish the model that evolved into the modern Poison Control Center. The idea spread quickly.
By 1958,
hundreds of poison control centers were operating around the United States. Their calls revealed something education alone could not solve. Parents were repeatedly told to place medicines high on shelves, keep chemicals locked away, and watch young children closely.
Those warnings were important, but young children did not behave predictably. A bottle left out for a few minutes during illness could be enough. A purse placed on a chair could bring medication down to a child's height. A grandparent visiting for the weekend might carry pills in an ordinary container. The exposure often happened during normal household life,
not because a family had consciously ignored danger. A 1960 study from St. Joe's found the greatest poisoning risk among children 1 through 3 years old. Drugs accounted for about half the cases. Investigators noted that the poisonous material
was often simply within reach. Aspirin became one of the most visible examples because it was everywhere and because
large doses could be lethal. By the 1960s,
aspirin poisoning was the leading cause of childhood poisoning death in the United States. That statistic applies specifically to aspirin, not to every kind of household poisoning. Other medicines and chemicals cause serious injuries as well. The government tried smaller interventions first. In 1967, limits were placed on the number of tablets in bottles of children's aspirin, reducing the amount a child could swallow from one package.
Poison Prevention Week campaigns encouraged safer storage. Poison centers gave parents immediate advice after an ingestion. Those measures helped, but
they still assumed the child would eventually
reach an ordinary closure. The next idea attacked the problem at the moment before the bottle opened. If adults could not supervise every second,
perhaps the package itself could buy them time. Chapter 2: Designing a cap a child could not easily open. The idea of a safety closure did not begin with President Richard Nixon or with the law he signed in 1970. Inventors had already been experimenting with caps that required more than a simple twist. Patents from the 1960s described closures that demanded pressing,
squeezing, alignment, or several motions before the lid would release. The problem was more complicated than making a cap tight. A child-resistant package had to exploit differences
between the way a young child
and an adult manipulate objects. A very tight ordinary screw cap could defeat both of them. Designers
instead looked for actions that were understandable and manageable
for adults but difficult for preschool children to perform at the same time. Push while turning,
squeeze at two separated points, align hidden tabs before lifting. That distinction explains the technical term. The packages are child-resistant, not childproof. A determined child given enough time may open one.
An adult may accidentally leave one unsecured. The package is intended to reduce access,
not make access physically impossible. Researchers tested closures with actual children. That human testing changed packaging from an engineering guess into a measurable safety system.
If too many children could open a design within the test period, the package failed even if an engineer believed the mechanism looked complicated. Early field trials also suggested that the idea worked. During Senate debate in 1970,
supporters cited a large field test involving more than 600,000 containers over 2 years. The committee concluded that
child-resistant containers could prevent a substantial
share of medicine poisonings and that
voluntary adoption had not spread widely enough. Senator Frank Moss of Utah became the sponsor of the federal
legislation. His argument reflected a larger shift in safety policy.
Labels and parental warnings placed responsibility mainly on the household. Child-resistant packaging changed the product itself.
Before the mistake occurred, the proposed law was also deliberately broader than medicine. Congress was looking at household substances that could cause serious
injury or illness when children opened or swallowed them.
Drugs were central, but cleaners, solvents, furniture polish, and other chemicals
could also fall within the law's reach. The legislation did not tell manufacturers what the cap should look like. That was crucial. Congress understood that packaging technology would change. One company might use a two-piece push and turn cap. Another might use a squeeze mechanism.
A liquid medicine might need a completely
different closure from a tablet bottle. The law therefore focused on performance. The package had to be significantly difficult for children under 5 to open
within a reasonable time and not difficult for normal adults to use properly. That
phrase sounds simple. It would become one of the hardest balancing acts in consumer packaging. Chapter 3: The law did not change every bottle at once. In 1970, the crisis was large enough to be measured nationally. Historical public health reviews record 226 poisoning deaths among American children under 5 that year across medicines and other toxic household substances.
Aspirin was one of the most important individual drugs in that story.
But the packaging problem was broader than any single bottle. The first regulations were initially administered through the Department of Health,
Education and Welfare and the Food and Drug Administration. In 1973, administration of the Poison Prevention Packaging Act transferred to the newly created Consumer Product Safety Commission. The agency inherited a law built around human performance rather than a particular cap that made children part of the test itself.
Panels of young children were given packages for a fixed period.
If they could not open them, they were shown how and allowed to try again. The standard was deliberately uncomfortable for designers.
A closure could look ingenious on a drafting table and still fail if enough children figured it out. The Poison Prevention Packaging
Act became Public Law 91601 on
December 30, 1970. Richard Nixon signed it.
But he did not invent the cap. The statute created federal authority to
establish special packaging standards for household
substances when a hazard to children.
justified intervention and when suitable packaging was technically feasible, practical, and appropriate. It also placed an important limit on the government. The law did not authorize regulators to prescribe one specific package design. The result was a framework, not an instant nationwide replacement of every medicine cap. Product-specific regulations came afterward. Aspirin became the first major substance required to use child-resistant packaging. The aspirin regulation took effect on August 14, 1972. That date matters because it separates the law from the rule. Congress passed the PPPA in 1970. Regulators then had to identify particular substances, evaluate the risk, determine that suitable packaging existed, and establish requirements for them. Prescription drugs and additional household substances followed through later regulations. For the bottle maker, compliance now meant passing a human factors test. Under today's standard, at least 85% of tested young children must be unable to open the package during the first 5 minutes without a demonstration. After they are shown how the package works and given more time, at least 80% must still fail to open it. The package also has to survive repeated normal use. A closure that becomes easy for a child after being opened a few times does not accomplish much. This is why the push and turn cap became so common. Two shells can rotate independently until downward pressure causes internal parts to engage. An adult pushes, the parts lock together, and the cap unscrews. Without that coordinated pressure, the outer cap may simply spin. Other packages use arrows, tabs, squeeze points, or unit dose formats. The law did not choose the mechanism. It created the test that the mechanism had to survive. The early results were dramatic enough to make the inconvenience difficult to dismiss. CPSC reported that deaths among children under 5 from aspirin poisoning fell 48%. In the 2 years after the aspirin packaging regulation took effect, Poison Control Center reports of aspirin ingestions in that age group fell from 8,146 in the year before the regulation to 4,837 in 1974. Those are aspirin figures. They should not be generalized into a claim that all childhood poisonings fell by the same amount. Later research examining aspirin mortality from 1958 through 1990 estimated that child-resistant packaging was associated with about a 34% reduction in the aspirin-related mortality rate among children under 5, equivalent to roughly 90 deaths prevented during the study's post-regulation period. The package had not eliminated poisoning. It had changed the odds, but the same design that slowed a preschool child could also slow someone else. An older adult with arthritis did not experience a push and turn cap as a clever human factors device. They experienced it as a bottle that would not open. Chapter 4. When safety became too hard to use. Conflict was built into the law from the beginning. Congress wanted packages that were difficult for children but usable by adults. Those two populations do not divide neatly by age or strength. A healthy 30-year-old may open a push and turn bottle without thinking. A 70-year-old with arthritis, tremor, reduced grip strength, or painful joints may not be able to generate the same combination of force and rotation if the package became too frustrating. The safety system could fail in a different way. An adult might leave the cap loose. They might transfer pills into an ordinary jar. They might ask the pharmacist for a different container. The medicine would become easier for the adult and easier for a child. Federal law therefore included escape valves for many regulated non-prescription products sold on store shelves. Manufacturers may offer one non-child resistant package size if compliant. Popular sizes are also available, and the conventional package carries the required warning. Prescription drugs have a different provision. When the applicable rules allow it, a pharmacist may dispense a prescription in non-child resistant packaging at the specific request of the patient or the prescribing practitioner. That is why a safety cap is not an absolute requirement on every prescription bottle in every circumstance. The trade-off also changed the testing system itself. By the 1990s, CPSC was concerned that the adult tests used for child-resistant packages did not adequately represent older consumers. In 1995, the agency revised its testing procedures to include a senior adult panel ages 50 through 70. The goal was not to weaken child resistance. It
was to make compliant packaging easier for the people most likely to take multiple medicines every day. Modern
standards require at least 90% senior adult use effectiveness for the packages covered by that test. Packaging companies continued inventing around the problem. One solution was the reversible prescription cap. In one orientation, the cap engages the child-resistant mechanism. Flip it over, and the same closure can act more like a conventional cap.
Patents for reversible pharmacy closures appeared in the
1970s and have continued evolving since. This design makes the conflict visible in one object. One side
prioritizes a barrier against young children. The other prioritizes easy adult access. The safest choice depends on the
household. A home with toddlers presents a different
risk from a household occupied only by an adult with severe arthritis.
The law recognizes that difference without pretending the easier
closure is child-resistant when it is not.
This is also why the instruction to resecure the cap matters. A child-resistant package protects only when the
closure is properly engaged. A cap resting loosely on top of the bottle has failed before the
child touches it. The difficult opening motion was never supposed to be a test of patience. It
was supposed to create a delay during the few unsupervised moments in which
childhood poisonings usually begin. Chapter 5. Why the cap is still difficult more than 50 years after the Poison Prevention Packaging Act. The same basic problem remains visible in modern recalls. In December 2025, CPSC announced the recall of more than 50,000 jars of a lidocaine pain relief ointment because the containers used ordinary threaded lids instead of the child-resistant packaging required for the product. In January 2026, about 148,000 bottles of a multivitamin were recalled because their iron content triggered child-resistant packaging requirements that the bottles did not meet. 3 months later, a much larger recall involved more than 356,000 packages of iron-containing dietary supplements sold under multiple brands, and in April 2026, by recalled about 786,000 travel-size aspirin nasal spray bottles because the packaging did not meet the applicable child-resistant or alternate labeling requirement. The products are different. The principle is the same one.
Congress addressed in 1970. If a small amount of a household substance can seriously injure a child,
easy access through the package can become part of the hazard. Modern regulation now covers many categories beyond aspirin, including prescription drugs, iron-containing products, acetaminophen, ibuprofen,
certain hydrocarbons, imidazoline medicines,
and other substances meeting specific thresholds. The cap is only one layer. Safe storage still matters. A child-resistant package can be defeated by time, by damage, by an adult leaving it open, or by a child who learns the mechanism. Medicines still need to be kept out of sight and reach. That is why the language remains child-resistant, not childproof. Return to the prescription bottle in your hand. Push down, turn. The motion is awkward
because the package is asking your hands to perform two actions that a very young child is less likely to coordinate
successfully. That small piece of plastic carries the history of a much larger change in American home safety. The mid-century response to childhood poisoning began with warnings.
Put medicines higher. Watch children carefully.
Call a poison center when something goes wrong. Those measures saved lives.
But they depended on perfect behavior. The safety cap added another idea. Assume that someone will forget. Assume that a bottle will be left on the counter. Assume that a curious 2-year-old will find it. Then make the final
barrier harder to cross. The Poison Prevention Packaging Act did not invent every closure, and its rules did not transform every bottle overnight. What it changed was the expectation that packaging itself should participate in preventing the poisoning. The result saved lives.
But it also created a permanent design compromise. A
medicine bottle must resist the hands that should not open it without defeating the hands that need what is inside. That balance is why the cap can still be
frustrating, and it is why that frustration is there.